Okay, let me pull up my notes. Sorry about that. Welcome everyone to our April CLOVES Summit event. Um, I will be your host today. Lauren is unavailable this morning, but I'm excited to have all of you here with us and with Dr. Whitney Eng of Seattle Children's Hospital and the University of Washington. Today, Dr. Eng is going to present on the role of anticoagulation in patients with CLOVES. And after her talk, we'll have time for Q&A, and then we invite you to all join us in our social space in GatherTown. I'll post the link in the chat so everyone has it easy access. And we'll have space there so that you can chat with our wonderful sponsors from Relay Therapeutics and Althea's Footwear Solutions. So definitely visit them. We're in the space. All right, well, I will turn it over to Whitney.
Thanks so much, Noreen. I'm going to try to share the presentation. Okay, can you guys see this?
Yep, all good.
Perfect. Well, thanks so much for inviting me to speak today about anticoagulation and cloves. I really feel like it's a privilege to be able to speak with all of you, and I'm looking forward to our discussion afterwards. I'm a pediatric hematologist oncologist at Seattle Children's Hospital, and I direct our Vascular Anomalies program. And today I'm really focused on talking about the use of anticoagulation in CLOVES syndrome. I do have a few disclosures that are related to my work as a vascular anomalist and a clinical trialist, and that includes some grant and research support from Relay Therapeutics and Merck related to clinical trials for vascular anomalies. And then I will be discussing off-label use of medications. These are medicines that have been used in vascular anomalies and in pediatric patients for a long time, but they're not FDA approved for this specific indication in cloves. I just had a few objectives for today's talk, and that includes understanding the role of anticoagulation in cloves, reviewing anticoagulation agents, the specific medicines, and some strategies about using them, and then applying decision making through some example or real world cases. And then importantly, exploring how anticoagulation can impact quality of life in patients. And then I also am really excited to learn, this is what has been the experience on this side, but I really am excited to learn what you all think about anticoagulation and the experience that you've had with practitioners about that and things that you would want your care team to know going forward. As a hematologist oncologist, I always put a little bit of I say disclaimer slide, but the role of the hematologist oncologist in caring for patients with CLOVES generally has really expanded. And I would say that out of all of the specialists, I would say maybe we're some kind of more newcomers. It's not really the case anymore, but in addition to what our surgical colleagues and interventional radiology colleagues have to offer, I will say that the use of medical therapies just generally has really exploded in the last few years. In the past, hematologists and hematologist oncologists, I think, were involved primarily related to anticoagulation and the fact that patients with vascular anomalies can get both clots and bleeding issues. But now, as you all know, that has really expanded, that there are these targeted medical therapies. And in many ways, that has become an even greater role or a complementary role. And the reason to be thinking about this specifically for patients with CLOVES is that patients with CLOVES can experience important, in some cases, even life-threatening complications related to bleeding and thrombosis, or a fancy word of saying clotting. And then we become involved just sort of throughout the course, throughout a patient's journey. But there are often important decisions that are made around the time of procedures. And then the use of other medical therapies in addition to anticoagulation is really important. I also view our role as hematologist oncologists as in many locations throughout the country and throughout the world, I do think we often serve as the medical home, that we know that the care of vascular anomalies patients and patients with CLOVES is very interdisciplinary, but having a single home, whatever home that is, but having a single home can be helpful in coordinating care among multiple specialists and across multiple sort of settings within the hospital. Just to sort of briefly describe vascular anomalies and CLOVES, I do use these analogies in patient rooms and encounters that patients with CLOVES can really have a variety, run the gamut of different types of vascular malformations. And the reason why I put a water balloon here, I don't know if you guys agree that this is a good analogy, but I think of lymphatic malformations as these water balloons that have a structure and a wall, and then they're filled with lymphatic fluid, and they can increase in size during flares. They can be painful. I guess it doesn't really work for a water balloon, but they can get bigger and smaller. But that kind of that structure, that shape is helpful, and the idea that the fluid can be removed, but often they can recur. Primarily today, we'll be talking about venous malformations. We know patients with CLOVES can develop both capillary malformations, so it's dark, red, pink, um, quote, stains on the skin, as well as arteriovenous malformations or abnormal connections between slow flow and high flow blood vessels. But I am primarily talking about venous malformations with anticoagulation today. And I don't know also if this analogy hits, but I think of a tangled web of noodles, right? Or like spaghetti, often because even when we get cross-sectional imaging or imaging that cuts through a venous malformation, it does, to me anyway, look like these different vessels that are sort of interwoven. And when you sort of, on an image, when it's sliced, they look like you're cutting spaghetti in the side. So that's often how I think about them. And then I should just say that please feel free to stop me at any point throughout this. So I'm just kind of going through and I can sort of see on the right that if there's something in the chat, but let me know or just please speak up as I go through it. But venous malformations, they can be both localized, occurring in one spot, or they can be diffuse and occur in many locations throughout the body. And they often can bleed. They can bleed on their own, and they can bleed when sort of traumatized or like hit or something happens to them. And that can include the things that we do, meaning getting surgeries or getting procedures. And they can be extremely painful. And I don't need to be one to tell you that for patients who have venous malformations, but we really hear that this pain can be very debilitating, chronic, and not amenable to pain medication specifically. But we can talk more about that. And then they are associated with these phlebolyths, which are these firm rock-like, like pebble-like calcifications that occur in blood vessels due to slowed blood flow. And then venous malformations are also associated with a term that is a term that the community, the vascular anomalies community, has sort of created called localized intravascular coagulopathy. And this is to distinguish from another entity called disseminated intravascular coagulopathy. In that condition, the disseminated form, patients have spontaneous bleeding from really anywhere. They can bleed from their nose, they can bleed from their mouth. And it's usually a sign of an overwhelming illness, the disseminated version. Localized means that when a patient gets their routine labs done, usually, that they have these differences in their lab numbers that just by number can be extremely concerning looking. So the elevated D dimer, so the D dimer can often be beyond the limit of normal for that laboratory. It will flag red and look, angry in the lab, um, just severely beyond the upper limit. And then fibrinogen, which is part of our clotting and coagulation cascade, it can be very, very low. And often you might even get a page from the lab to say this is a critical result because it's also beyond the lower limit of normal. And we'll talk more about the implications of localized intravascular coagulopathy. But depending on the location and extent of venous malformations, they can also be a risk for getting blood clots. And this is really a focus of today. So I think of three main indications or three main reasons why a patient might need anticoagulation. And I just made them three different colors, but I think about them in this way. And a patient can have any combination of this. They can have one or none, or they could have all three. And the first one we'll talk about is prevention of deep venous thrombosis or pulmonary embolus, like a blood clot in the lungs. And this is the most sort of classic use of anticoagulation when you hear about it just in ads or if there's a TV commercial for why is anyone, pediatric or adult, on an anticoagulant. Um, I thought it would be good to go through a case, if that's okay. I think it's helpful to just think of like potential examples. These are all fictional, but they're based on real life situations that have happened. And then another sort of thing to discuss is that these are just meant to be illustrative of what could happen. But please let me know, if there's sort of questions about it, because the idea is just to say like this is something that could happen, but that doesn't mean that's going to happen to everyone. It's meant to just be a learning case. Um, for example, in this case, a 10-year-old patient who is a girl, I should have said that, with CLOVES undergoes a surgical debulking procedure. And then 2 days after the procedure, she tells her parents that her leg hurts and it feels heavier than usual. And then when they look, it is much more noticeably swollen than um, it's really warm and it's very different from her baseline. And then importantly, she feels out of breath. And when they are evaluating her, her parents are looking at her and they're like, she just seems like she's having some more difficulty breathing than usual. And they astutely bring her to a local emergency room. Um, and then uh, at the emergency room, a chest CT type of imaging of the chest is performed based on those symptoms. And she's noted to have a clot in the lung. Again, we call these clot in the lungs pulmonary emboli, embolus, emboli, based on its relatively small size. And I say this because you can have involvement of the pulmonary vasculature, the pulmonary blood vessels that can be on the smaller side, or it can be extremely significant, really clotting off many of the major blood vessels. She started on anticoagulation. And I say this because there's additional types of procedures or types of interventions that can be given for clots, and that can include a different type of anticoagulant medicine that's directly instilled by a catheter, or even in some cases, a procedure is done with an interventional radiologist to do what it's called thrombectomy or remove, like physically remove the clot. And a similar procedure can be done by a general surgeon. But just for the purposes of discussion, she started on a medicine, which is a really effective therapy for certain types of clots in the lung. She continues on the medication for 6 months, and then the repeat imaging is done, and the clot is no longer there. And throughout this process, very importantly, her family asks the team whether or not patients like her who have CLOVES syndrome are at increased risk for clot. And it's just meant to be sort of a discussion starter. And I really do want folks to chime in if they can, just about this idea of whether or not folks have been told that patients with CLOVES are at risk. I don't know if anyone wants to share their thoughts or experience.
And feel free to just come off mute if you do have a question.
I'm actually really curious on whether this conversation has changed over time. I'm now 30, and I started on enoxaparin when I was 11 after having pulmonary embolisms. In leading up to that hospitalization and during that hospitalization, my parents had always been told we wouldn't have to worry about clotting because I'm mostly affected by, at the time, it was Klippel-Trenaunay syndrome in my upper body. And so it was like, no, this isn't a concern, not a concern, not a concern. And for me, after having PEs, that drastically changed. And I've been on enoxaparin since. So I'm curious on if the conversation has actually changed over time, where maybe we don't have as many providers saying, no, this isn't a concern. We don't think it will be an issue for you.
Mhm. Got it. Oh, thanks so much for sharing that. And I thank you for sharing that. And I hope as I was preparing these slides, I definitely was thinking, was like, I hope this doesn't trigger anything for anyone because clearly these are really impactful things that happen to folks. So I really appreciate you sharing that. And we'll get into it a little bit, but my take on it, I'm curious what all of your take on it is I do think, so Klippel-Trenaunay syndrome, which is another one of the PIK3CA related overgrowth spectrum conditions, does have, I would say, more of a track record, more of a literature, like published literature, and also maybe an increased understanding among providers. Again, many providers, I think, just in general, may not know of the association at all, but among vascular anomalists, the one that gets like the bad rap of having the worst clots is Klippel-Trenaunay syndrome. And there's some pictures and we talked about it. But my take is that anyone with abnormal veins, and that can be within the context of vascular anomalies, CLOVES syndrome, Klippel-Trenaunay syndrome, or patients who have venous differences for other reasons, that's the issue. It's the setup that if you have abnormal veins, it matters less like what you have, like globally, it's the venous malformation that is due to really an embryonic variant or a difference that occurs as part of genetic mutations, but it's not limited to Klippel-Trenaunay, it's not limited to cloves, and really without looking at the veins, you can't really know. In terms of practice at our institution, we look very carefully at all patients who have overgrowth, like one-sided overgrowth or both sides overgrowth. But this idea that if you have veins even on the surface when you're looking at someone's skin, or that they have overgrowth, where we say we want to know what's happening underneath the surface, folks will get venograms of both the upper extremities and the lower extremities. And so it's not that Klippel-Trenaunay syndrome patients are the only ones who we do that imaging for. But I do think, to answer your question, I do think it's changing, hopefully for the better, that folks say like, pros, and we can talk about this maybe at the end too, that pros I think is a really useful condition in some ways, right? It's a really broad umbrella term, but then sometimes it can be a bit confusing because people say, well, which features do you have of pros? And in this case, do you have the relevant ones, which are, do you have abnormal veins that are predispose you to clots? Yeah. Did you have other thoughts about that or questions? Yeah.
No, I'm just curious because now that I've been on blood thinner for so long in my kind of care setting, it's just like normal for us to acknowledge that this is going to be a long-term medication and concern for me. And so I'm curious, especially for our younger patients, how those conversations have gone. If it's just, we've learned more, we have a better understanding. Because when I was a kid, there just wasn't, it seems like there just wasn't an understanding that this was a legitimate concern, even if I didn't have the classic overgrowth on the lower extremities.
Mhm. I think it's a really important point and something that within the community of hematologists, oncologists, or others who might be prescribing anticoagulation, or on the surgical and interventional side, that there's increased awareness. Because depending on the age or just how folks come to us, I think that being very intentional to say, we do think you're at risk or we don't, and the reasons why, really requires a bit of workup to reassure someone. And then the other thing I do tell everyone is that separate from having a vascular anomaly, separate from having CLOVES syndrome, we all, as people, are at risk for clots over life, and there are different risk factors that can predispose us, and that risk increases as we get older. And so, folks who are on estrogen for any reason, being immobile on a plane or on a long car ride, having being dehydrated. And so even separate from any intervention that you get from that you get related to cloves, we all are at risk for clots as we get older, unfortunately, it's an unfortunate truth. But anyway, so I think good vein health, which seems kind of a simple thing, but it's like really avoiding immobility as much as we can, and then being and thinking about that. But anyway, I think there's increased awareness in general among practitioners in some of these dividing between the names and thinking at an early age, like you mentioned, is important. So some of this I think we'll go through, but at the end, definitely let me know if there's other sort of considerations that we didn't touch on. Yeah, perfect. Any other thoughts before moving on? Okay, I'll just keep going then. Let's see. And so the answer to this is some can. So it's, meant to be sort of that was a perfect example of the fact that not everyone, so the message is not that every patient with CLOVES needs to be on an anticoagulant. It's that every patient with CLOVES need to be thought about whether or not they need to be on an anticoagulant. And so patients with CLOVES can have dilated in different veins. Sometimes the word is that folks use is dysplastic, just means they were formed differently. But those differently formed veins can have slowed blood flow, and we call that stasis, just sort of staying, not moving. And in the example case, I would say that this is sort of historic as well, that this patient, the reason to say, it would be sort of, at least to me, alarming now, I'd be like, oh, that's terrible that that happened. But the vein mapping was not performed. There was not sort of anatomic mapping. And then there was not really a discussion about perioperative anticoagulation, both before and after the procedure. And we know that surgery and intervention, for a lot of reasons, can be high risk times for developing clots. And so just being very thoughtful about it is really the goal going forward. And then just in general, what causes clots? And this is a bit of a busy slide, but we as hematologists love thinking about this academic idea or this idea of Virchow's triad. And so this triangle, right? That all three of these things are really important for developing clots. And at any given time, we may have one or all of these issues. Um, what we were just talking about and having dilated embryonic veins, which classically this vein of Serval, this eponomic name is in Klippel-Trenaunay, but that can be in any patient, and often in patients with CLOVES. Having central or thoracic, the word phlebitictia, but differently formed veins that are predisposed to clot. And we touched on this as well for stasis of blood flow, immobility. So you are recovering from a surgery and you're stuck in bed. You have to travel to come see your providers and drive for a really long time to see them. Or, very importantly, you have chronic pain and moving around is very difficult. And then I do think, not to blame the IR folks, but post-sclerotherapy, they do change the blood flow, right? And that's sort of the point, but there can be flow disruptions that lead to stasis and the blood flow not moving well. And then on the left side, endothelial injury. So endothelial just meaning the lining of blood vessels, that we have endothelial injury actually every time we get even just a peripheral IV. A peripheral IV is not the same risk as having a central catheter that's left in place, for some period, like a PIC or like a port or something. But those all put us at risk for having clots. And then again, it's just a truth that having repeated procedures where you're having lines placed or having repeated sclerotherapy, which the point of sclerotherapy is to create a scar that can be um, kind of bad for veins and cause injury, and that can predispose folks. And then on the right side, we have hypercoagulability. So, as I mentioned, anytime anyone is on estrogen or they're pregnant, that can be a big time for having a clot. And then when we are inflamed, acute illness or infection, we're more likely to clot. And then what I want to move towards and talk about in more detail is this localized intravascular coagulopathy, or this unique changes that occur in patients with venous malformations. And it's like we predicted it, but this idea that classically Klippel-Trenaunay as a prose condition is the one that maybe has the most sort of awareness among folks, that it is a prothrombotic or pro-clotting condition, and sort of described as this abnormal vein, goes by different names, but a lateral marginal vein, this vein that exists on the side. And I have another picture, sort of on the outside of the leg, and also called the vein of Serval. But these patients have an increased risk of thrombosis. And so often they will have imaging done to really interrogate those veins and map the anatomy. And early on, and I do think this has changed, but early on, many patients would have these veins, quote, closed by interventional radiology. I put it in quotes because I always say that these procedures, they're not absolute, especially as people get older over time. The things that are done, which are important, they can they can evolve. So like coils can move, they can be removed, one can even still get a clot with them present. So I'm just very cautious about all of this. But yes, these are important things that are often done before children are sort of school age to close them to decrease that risk. Um, and then just to show the pictures a little bit more. So this is that lateral marginal vein or vein of Serval. And this is a patient who is described as having Klippel-Trenaunay, but this can occur in CLOVES patients as well. And sort of just say that there, that depending on sort of the distribution of patients who have CLOVES syndrome, kind of the distribution of their differences, there can be a risk. And it's really the involvement of their deep venous system. So when we all look at our veins, like on our arm, and we see the blue veins, it's more superficial. Usually the deep veins are just harder for us to visualize without the help of some imaging. And the management in terms of prevention of PE, pulmonary embolus, or DVT, deep venous thrombosis, can be both surgical, interventional, as we talked about, and then the focus as a medical person is on the anticoagulation. There is some data to talk about the risk, particularly in CLOVES, about the risk of clot. This is old, so I think it does behoove us as a patient community and scientific community to say, like, well, what is it now with sort of these changes? But just to go through these sort of older articles, and they're very small numbers. This is 12 patients with CLOVES, but 11 had what we would call central or thoracic phlebectasia, this word for dilated veins, and two did have pulmonary embolism. The way the study was done, it's important, is that it was a retrospective review. So patients who were described as having CLOVES, the authors looked back and said, sort of after the fact, right? Like how many patients overall were cared for, and how many of them developed a pulmonary embolus or clot in a certain amount of time. But I think the main point is to say, even separate from Klippel-Trenaunay, patients with CLOVES do have risk of developing clots. And many of this happened around the time of procedure. So prophylaxis or preventative anticoagulation should be considered and thought about before major interventions. There's another relatively old, I say old 2018, but I mean, it is old now, like case series of patients. And this looked at both patients with Klippel-Trenaunay and CLOVES. Just as a disclaimer, right, as you all know, many of these patients, these folks, I wonder if they would even be called CLOVES or KT now. Maybe there'd be some differences in how folks are thinking or grouping folks. But either way, of the patients who were described as having CLOVES, 10 out of 110 had a pulmonary embolus, and 12 out of 96, so each group had about 100 patients. But it's not nothing, that these patients had these risks. And 64% of all the events occurred around a time of a surgery or sclerotherapy. So that's important, as we've said. And all the patients, it wasn't that they all had abnormally dilated veins, meaning that when you look for it, it wasn't like there was a hidden reason why they got it, if that makes sense. And then importantly, yes, this can be a significant thing. So two patients passed away from pulmonary embolus. This is just a key, we say just a case because it's one person, but I think it's important. I just wanted to highlight that this is a patient with CLOVES who had clots in sort of both sides. And this patient did not get anticoagulation. They were treated with what we call catheter-directed thrombolysis, where a catheter is placed in one of these areas near a clot to sort of bust up the clot, like a thrombolytic, something that is meant to break down the clot, is placed. This is a kind of a nuanced thing that at most institutions there's a workup and a workflow for who needs anticoagulation, who needs catheter-directed thrombolysis. But either way, just to show a different example that this was treated more interventionally than medically. Um, and so, I just said these three things. So what does this mean? So the increased recognition is important. And many patients are on anticoagulation already before surgery these days, and we'll talk about reasons why. But if for some reason they're not, a specific anticoagulation plan should be made. And so we do at our institution have perioperative anticoagulation plans that are made well in advance, right? Not the day of the procedure, right? Well in advance of when someone is going for a procedure, and that both the surgeon, interventionalist, anesthesia, and a hematologist are all involved in that plan. In understanding a patient's vein anatomy before doing any procedure is important to understand that risk. But again, the point is not to say, this is a blanket statement that all patients with CLOVES are at risk. It's that there really needs to be an assessment of the veins beforehand. Questions about that? Um, this is a different example. And again, these examples, I don't want them to seem overly extreme. They're just meant to be informative. This is a patient who actually does not have CLOVES, but I thought it was a good example of venous malformations. And as we know, patients with CLOVES can have a variety of venous malformations, including diffuse venous malformations. But just as a disclaimer, he does not have CLOVES. He has diffuse venous malformations, not from a PIK3CA mutation. But I think the example makes sense that he has venous malformations that involve his airway. He has a tracheostomy as a result. And as you can tell, there are these differences on the tongue. And he was eating a piece of pizza, and I was a fellow at the time. And he called in to have and said that he had profuse bleeding from doing something so, innocuous. And in his case, his venous malformations affected his airway. He had really received the gamut of therapies with surgery, sclerotherapy, and he's an adult, so he did receive interferon as a baby, which we no longer use as a therapy. And he has severe localized intravascular coagulopathy, those coagulation changes. And he's had very significant bleeding events, including having a rectal venous malformation that often bleeds and is very problematic. And then within his life, had many transfusions at the time that I was thinking about this, had close to 90. And then, as is the case for many patients, getting a biopsy of affected tissue is dangerous because he's already at risk for bleeding. And then his mother, sort of asked, "Is there anything that can help prevent the severe bleeding with the pizza, right, in the future?" And this is just meant to highlight that this localized intravascular coagulopathy is a unique phenomenon that occurs with patients, any type of patient who has a venous malformation. And it does seem to be correlated with the size of the venous malformation, so larger venous malformations as opposed to having a small venous malformation in one spot. But either way, this is something that we check or we monitor by getting blood tests. And we see an elevation in the D dimer can be extremely high, the limit of detection, or extremely low for the fibrinogen. This is important because it's important to kind of know your own numbers when you're well or at baseline, because if you go to an emergency room and for whatever reason, if they check this and you might not know what your normal is, the numbers can be sometimes very alarming, right? Folks can say, "Oh my gosh, you might be having a blood clot right now." That doesn't mean you are. It's sort of there are folks who at baseline they can have abnormal numbers. So I do think when folks are well, we often are getting labs to know what the baseline is. But it's a very sort of paradoxical thing that we give anticoagulation, a blood thinner, to treat a difference in the coagulation factors. And just having done this for some time, it's interesting even working with the surgeons, other medical professionals within our teams to say it's safe and we recommend you giving a blood thinner for the patient you're about to cut into. And it really took a leap of faith to say this is a phenomenon, meaning giving anticoagulation can actually increase the numbers. That they had to kind of do it a few times. And now many are like the best, the strongest believers and say, "Oh, yeah, we don't want to hold the anticoagulation before procedures. We want to continue it." But just practically, it seems very counterintuitive to give a blood thinner to someone who's at risk for bleeding. But it's only patients who have venous malformations that works. And so this is actually, I said there are example cases. This is a true case, and I have permission to share it from the patient. But this is the use of both the enoxaparin early on. It's all sort of bicolor, so this light beige color. And then we now have oral anticoagulants that we use. And he was started on an oral anticoagulant. As many of you know, alpelisib or Vidroys came into the fray as part of this. And he actually is on alpelisib or Vidroys, and that has really helped so the top is the D-dimer, which it has helped decrease the D-dimer, which is good. It has increased the fibrinogen, which is also good. And then he was getting very anemic, and as a result of each of these therapies, the anemia, right, the degree of anemia got more stable. And in this case, he had some differences in platelets that also got better. The weight is interesting because one might say, well, we don't want folks to lose weight, but in this case, it was really a positive thing. He was exercising more and feeling better. And so this weight loss was like a good thing. And also there was some decrease in size of some of his masses on like the venous malformations on the alpelisib. Just to go through the anticoagulation agents a little bit, and I'm happy to discuss them in more detail. I've already talked about low molecular weight heparin or Lovenox. And the way that it works, it enhances antithrombin. Your body has both, it's kind of a seesaw of both pro-clotting and anti-clotting. There's a system of pro-clotting and a system of anti-clotting. And so in a way, Lovenox basically enhances our anti-clotting abilities, and it's so it works differently than the oral agents I'm going to talk about. And in some ways, it's a little bit they call it like less direct, but this is a very tried and true medicine. It's a medicine that we can get levels on. It's a medicine that has a lot of safety data. It is a medicine that's given by injection. So as you can imagine, right, there's pros and cons of doing that. And then I know there's a lot of adult data, but just to say in children, this has been used in children for prevention and treatment of clots for years and years and years. So it's again tried and true. And often, depending on the setting, this is the first medicine someone might start for a new blood clot. That some of that is changing, but either way, it's very reliable. And once you're on a stable dose, it has very reliable therapeutic levels, meaning that as hematologists, we know that you're getting kind of the right amount to work effectively. The biggest downside is the administration, and in getting the shots. And for children, it's often twice a day shots. Um, this I just put here because this was sort of an algorithm where I worked in Boston before. We are folks around the time of procedures. Again, this is changing because many patients were on blood thinners now chronically, right, throughout the whole year, but at least around procedures that if they had LIC or those abnormal coagulation studies, they would receive Lovenox and Enoxaparin 2 weeks before and 2 weeks after. It was kind of a made up thing, but to cover folks around this high time of getting procedures and being at risk for clots. It is somewhat historic that many patients don't get Lovenox anymore, and they also are on blood thinners outside of procedures. Talking about the direct oral anticoagulants, which are other medicines, they have this acronym of DOACs, and they directly block factor 10A, which I do put here on the left, but either way, it's a key step in the clotting cascade, preventing clot formation. Even among hematologists and among our hematology trainees, no one really likes the coagulation cascade. So I put it here not to say like this is to be memorized, but the main way that I think it is the chain reaction, right? So one thing sets off the next thing, and that sets off the next thing. So the direct anti coagulants, they directly block factor 10A. And so here they list, it's a little hard to see, but this red we're talking mostly about Abixpan and Rivaroxaban, but they block this central part, right? The central part of creating fibrin, and fibrin is the like cross-linked or like the mesh network that makes a stable clot. So either way, this is just a pharmacologic way of sort of stopping clot production, and it's directly on 10A, which is a central part of the anticoagulation cascade. The two main oral anticoagulants that are used, they have a generic name and a brand name. So Rivaroxaban or Xarelto, there's a liquid form, and it has been approved for children in 2021. The pros are that, right, like it's convenient in terms of having no injections. This is something that we have less data on the levels. We can get, at least our institution, we can get Rivaroxaban levels on a adult or pediatric patient, but how to interpret it, I think, is a bit it's not clear how to interpret those levels. There's still a lot of kind of information to get. It's helpful if it's really low or really high, but in the middle, it's a little hard to know. And that's the same for the other blood thinner, Apixaban or Eliquis. This was approved just a little bit later. And one thing just to distinguish it a little bit from Rivaroxaban is that for patients who have periods, those when you're on a blood thinner, it can make periods heavier, and apixaban or Eliquis has been associated with less of that bleeding. It is typically twice a day dosing as opposed to Rivaroxaban, which in adults anyway is once a day dosing. So just practically, even it has the benefit of having less bleeding with periods, but then you got to take it twice a day. So anyway, one thing that I didn't put here, but it belongs in the section about anticoagulations. Are they safe? So they are generally extremely safe when monitored carefully, right? When they're given at doses that are prescribed by folks who prescribe this very commonly. The main side effects are bruising or some minor bleeding. People might notice that they bruise a little more easily. And then as we talk about periods is one thing that can be heavier on them. Serious bleeding, meaning, and just say it, bleeding in your head, bleeding spontaneously from your bladder, like having just sort of bleeding with no reason is extremely uncommon. But we watch all patients on blood thinners very carefully, and have a lot of guidance about this. Um, One thing to say really quickly about reversal agents, if in a trauma setting or in a setting where you would need a reversal agent, the DOACs, the oral anticoagulants, they technically have reversal agents, but many hospitals might not have access to them, or there's some limitations to that, I should say. And in particular, one of the reversal agents is sort of coming off the market or has come off the market. Um, that isn't meant to, it sounds scary. The idea is that for a lot of older patients, I would say, many patients who don't have cloves, um, who are at risk of having bleeding events, and they don't have this unique phenomenon of a localized intravascular coagulopathy, are at increased risk than I would say our patients with venous malformations are. But it's just an important thing to kind of talk about. And then I mentioned that, mentioning off-label use, but what does that really mean? The medications are approved for children to use for clots, prevention of clots, treatment of clots, but they don't have a label. Like on the label, it doesn't say that they're approved in cloves. They're approved for other conditions. And so for the use of it in venous malformations and preventing and treating the localized intravascular coagulopathy, we use that and we commonly use it based on sort of expert experience, but the drug label does not say like give for cloves for venous malformations, if that makes sense. And then very important questions about playing sports and staying active. We do encourage folks to play sports and stay active on anticoagulants. Some precautions might be needed for really high risk activities. And that's really separate from being on an anticoagulant, right? Like things that you could hit your head is not good for your head anyway, separate from a blood thinner. But so it's a very individualized treatment plan. So we often ask folks, what do you like to do? And, try to work really closely on how we can achieve that. Um, and then I just make mention of just briefly, right? In addition to anticoagulation, the landscape of agents is really changing for PROS conditions in general. So we have sirolimus, we have alpelisib, and in many ways, I think, in my opinion, those agents help venous malformations in general. But for someone who's like needing to be prevented from getting a clot, I would never say, oh, today in this moment, sirolimus is an anticoagulant, right? It's a medicine that may help improve your venous malformation, but I wouldn't say, oh, you're on sirolimus, so you don't need anticoagulation around a procedure and that kind of thing. So I don't know if that makes sense, but I think they're very helpful adjuncts, but they're not replacements for anticoagulation. And then just as a third example, and as an example case of really the pain, the importance of pain relief, that this is an example of a patient with venous malformations of the arm and chest wall, really, I should say. And it's really painful. And as a younger person, they were able to play more sports, but now it's like really, really hard to play sports and can't throw with that arm, and that's their dominant arm. And this is really affecting their quality of life. Um, and you can see like they have all of the sort of features of venous malformations on the right, like in terms of the lab studies. And this patient, as many of you know, right, was on sirolimus, meaning because like sirolimus is used for these conditions, with some improvement in pain. But even on sirolimus, it really wasn't like enough to help the pain to participate in sports. And we started oral anticoagulation with apixaban, and the pain scores, very magically improved. And in asking, do you have any pain? The pain really went to zero. And I said, is it really zero? Like, are you just sort of saying, is it really zero? Zero seems so incredible compared to 8 to 10. And now we have this other, I say issue, but it's not really an issue, but now they're feeling so well, they want to play a contact sport. So it's kind of like this, the positive of this all. And I think a question which I don't have the answer to, and I'm curious on what all of your thoughts are, but does having anticoagulation or treating a patient very young with anticoagulation, does that actually change the natural history? Like in some cases for diffuse venous malformations, I think it could, meaning that I feel like people are having less complications than some of the adults that I've taken care of, but it's a kind of a difficult thing to prove over time. Um, and then just this is like some practicalities in terms of the management. When we have an anticoagulation plan, we really try to limit holding of doses. Typically, patients who don't have vascular anomalies, when they get procedures, they often hold 1 or 2 doses or even more before a procedure because of the risk of bleeding. But we try to educate to say, no, folks are usually at risk for bleeding they're at greater risk of bleeding off of their anticoagulation. And so, we make a very specific plan. And then in terms of what the anticoagulation management involves, it does involve enrollment. During enrollment, we first start getting some baseline labs to make sure it's safe to give these things, meaning from a liver function and just organ function standpoint. Typically, most folks are in a very good spot for this, but there are some considerations, particularly in CLOVES, where there can be kidney issues. We want to really dose things very carefully. And then PROMIS course, which we'll talk a bit more about patient-reported outcome measures. So we have baseline measures of pain and using this over time to say, how are we doing? And this is sort of just our like internal protocol that we do in Seattle. Um, and then there's some data to say, not just at our institution, just in the world, that anticoagulation can improve quality of life in patients who have venous malformations, that there's improved functional limitation and reduced swelling and discomfort, and that there's a benefit even if you don't have a clot, right? That the pain improvement really can be impactful. And then many of you may have, I don't say been forced, but have requested to fill out these surveys at your visits. I really hope so, because I think they are good measures of trying to look at pain over time. So this is a short form for, I think, this is adult, but it asks a few questions to try to really say, like, how is your pain? And we use these as indicators over time. And I think this is really important because we can have imaging, and as all of you know, the imaging has some, caveats to it, but really how are people feeling is really the most important. And then we do try to replicate this in clinical studies to say, let's use these patient-reported outcome measures. They're not usually the primary outcome, but they're often very important secondary or ancillary outcomes to say, is the pain getting better? And then in the clinic, it's like the most important outcome, like seeing changes in this. Um, and so just to summarize, those 3 examples were to talk about when patients might need anticoagulation. The first one, if you remember, was around a procedure and you need a prevention strategy. And I would say really not hold anticoagulation for someone who's already on it, or think about starting it for someone who isn't. And then the second is that coagulation, coagulopathy, severe LIC. And we really also don't want to hold anticoagulation around procedures, but also be thinking about abnormal numbers and what someone's numbers are when they're well. And the last one is having these drugs available and seeing if they can help improve pain and quality of life and symptom management aside from a procedure and aside from having a clot. And then in case folks have questions, the doses that we start are often not what we call treatment dose. Even at half the dose of a treatment dose, folks can report improvement in pain. And so my personal approach is always starting low and going up slowly, because if the pain is improved at a lower dose, it's, less is more. It's better to do that from the pain standpoint. But then if you're treating a clot, yes, you give full anticoagulation. And then this broad idea of minimizing interruption around procedures. I think a major consideration is that these are just examples, but it's very individualized to each person. That the risk varies widely across patients, and these decisions really need to take into consideration someone's anatomy, right? Kind of the distribution of their veins, what's happened to them in the past, and it's really important to follow with the care team, and really having open communication about any concerns or side effects, because we always want to know what folks are on and not adjusting the medication sort of on their own. And then, so key takeaways are that CLOVES can be a prothrombotic or pro-clotting condition, and that it's these venous abnormalities, these differences that can drive risk. Having immobility or not moving very much, having procedures, and having the lines and catheters can also increase risk, as we talked about. The use of anticoagulation is very individualized, and then multidisciplinary care, meaning among the care team, the entire sort of medical team, but then also very much making decisions and shared decision making with patients and families is really important. So anyway, I just thought those were some things to to get the conversation going. And in terms of a community discussion, I just thought of some questions. But we've talked about some of this is like, have you or a family member ever been on anticoagulation? What worked well? What were some challenges? And I really want to know if anything that I said does not resonate with your like lived experience of being on anticoagulants. And then other things in terms of what would you like your care team to know? We try to go over the side effects and practical pieces, but I'm always curious if we're doing a good job at that. So anyway, I really appreciate the opportunity to talk about all of this. And that's all I have.
Thank you so much. We have time for questions if anyone has any here. And then also in the social time, we will have time there too. Sherry, I see that you have your hand raised. Go ahead.
Hi, this is her mom. The reason, I was wondering with the risk of clotting that exists with some of these venous malformations and with these PIK3CA mutation conditions, have they changed to stand, or is that pretty much individualized on cosmetic type surgeries? Holding off on those because of the risk of clot, or does that have to be determined just on an individual basis?
Oh, I see. I just want to make sure I understand the question that if there's more like quote cosmetic surgeries, should a perioperative plan with anticoagulation be made?
Well, I'm wondering,
Oh.
for example, my daughter at one point was thinking of a cosmetic surgery that was not medically necessary, but she was discouraged greatly from getting it because of her risk of clots. Has that lessened over time, that risk, or is it still the
Oh.
same?
I see. Oh, got it. I think from my perspective that any procedure that a patient is undergoing, I think to me, it's not, there's not an absolute contraindication, right? That if you're at risk of clot, you can't get a certain procedure. I think it's just that that working with a hematologist or a care team to say like, do we think this is safe? Do we think it's safe based on X, Y, Z? But there are patients who they get a variety of different things. And some of that is procedures like huge debulking procedures that's done with a general surgeon, or they have other surgeries that wouldn't be described as like clove surgeries. I don't know, but there's all sorts of different things that people get. And I think the main point is that uh, is getting is sort of working with the hematologist. I would say, usually it's us that we weigh in. So I've definitely made hematology plans for patients getting procedures that are, for example, like not at our hospital. This comes up even for like I'm just saying examples, and you don't have to share like what the procedure is if you don't want to, but like egg freezing, right? This is something that comes up. Sometimes people are getting procedures that are like not necessarily related to their vascular malformation, so they are living their lives and they fall off of a I'm going to say an ATV, they like doing things, and that's really not from their vascular malformation, but we want to be involved so that people understand the risk. I don't know if that answers the question, but there's no blanket statement that people can't get certain procedures. It's just that we have to try to understand the risk and give anticoagulation before the procedure if needed.
Okay, thank you very much.
Mhm.
Any other questions? All right. If not, we can move over to the Gather space, which I just posted the link in the chat for everyone. Once we get over there, I'll pop up. You'll see my face again and give some instructions and tips for anyone who hasn't been in the Gather space before. But just click that link. It'll ask you to put your name in, and then you'll be ready to go.
Okay, thank you.
Actually, I have one question,
Yeah.
and I was taking pictures from the slides, and I missed one, which I think was important about the study from 2010. What were the typical characteristics that were present in everyone that had a pulmonary embolism?
Yeah.
Which were dilated central something and primary something.
Yeah, yeah, sir. And thanks for calling that out. The all the clots were in patients who had venous differences that were if folks were to look at their imaging, I guess the point was to say there was no, like, quote, no hidden clots, right? Because I think might be concerning is if you have a venogram or you undergo some sort of imaging, an investigation, and it says you are not at risk of clots based on this. I mean, we're all at risk for clots, but you don't are not at risk for clots based on your venous anatomy. That all the patients who had the pulmonary emboli did have large abnormal veins. So centrally, we mean it's kind of silly because it's like a euphemism, or like we should just say what it is, but like you have veins throughout your body, but these are
Yeah.
large veins that have abnormal that they have a connection to your deep venous system, meaning that they're a setup for getting a pulmonary embolus. So the point of saying it was more that like none of the patients had normal, quote, normal vein anatomy. So they weren't like hidden, like if they had gotten the like appropriate, or they had gotten the imaging beforehand, someone would say like that was you are at risk for getting clot. So I don't know if that
And
explained that well.
so like AVMs are, because AVMs are not enlarged veins, right? So it's a different type of malformation. I'm
Mhm.
asking just because my son had well, more than one already pulmonary
Mhm.
embolism, and
Mhm.
he hadn't ever had a diagnosis of enlarged veins. He does, however, have AVMs.
Ah, I see. Got it.
So
And
that's why.
pulmonary, or not pulmonary, arteriovenous malformations in themselves are not at risk for clots. They are a connection between high flow and low flow. So if anything, it's interesting. There's often high flow and shunting, like the blood is going so fast, so the blood is not typically clotting. But then sometimes folks can get procedures related to their AVMs that, yes, like we want to think about. Anticoagulation. Typically, we don't anticoagulate even for surgeries around AVMs because the bigger risk in that scenario is bleeding because people are more at risk for bleeding. But I think what you're saying is that it was there were known AVMs in your son, and then, but this idea of being at risk for
Yeah, actually,
clots
now that
wasn't
I'm
known.
thinking, I think the AVM um, directed the flow to a vein that then became enlarged, not because it had something
Mhm.
in the vein that was naturally enlarged, but because the flow from the AVM was throwing a
Mhm.
lot of blood in
Right.
that vein. So that became enlarged. So maybe that's where the clot
Yeah.
came from.
Oh, it's a really good point because this is like in a way that's compensatory, right? Like that vein, which is normally probably thin and not having to work too hard, then had to work really hard because it's getting all of this blood flow. So I didn't get into it today, but I do have like different examples for each of or like analogies for each of the different types of vascular malformations. So the analogy for arteriovenous malformations is like a highway meeting a small road. So you have like a 5-lane highway, the artery, that has like all this blood flow. And then you have a vein that is like, I don't know, the street that you live on, which should not be it's not like a 5-lane highway, and you have a direct connection between those without off ramps. So in your example, this idea that the vein, the house, if you, I don't know, had a party or I don't know, something, whatever, you needed more traffic to go on your street, like you have an AVM, then it's going to need to like, the street actually won't widen. I don't think the city is going to make your street bigger, but maybe they would. But this idea, like, I don't know if that makes sense, that the cars are going so fast, you have so many cars, you need to accommodate that flow so the vein actually distends or like gets bigger.
Yeah.
So like, yes, if you were going to have a ton of people at your house on your small street, you might say, go park down the way or go park over there, and you might need to accommodate it in some way. Mm.
Yeah. Okay. No, thank you.
Yeah.
Right. I see some people have already jumped over to gather,
Okay.
so whenever you want to, we'll be over there.
Thanks.